Hi, my name is Ajay Kirthane, and on behalf of Michelle Azizi, as well as all the other investigators of the RADIANCE-HTN SOLO trial, it's my honor to be able to present to you the results of this late-breaking trial, which are the crossover results of the RADIANCE-HTN SOLO trial. These are my conflicts of interest. I think every clinician knows that hypertension is the #1 cause of global disease burden and actually is projected to remain the top cause in 2040. Despite the fact that we have multiple medications that are efficacious at treating blood pressure control rates have actually plateaued. And still, even in 2020, we find that up to almost 40% of patients have inability to actually control their blood pressure. One of the advantages of a device-based therapy to control blood pressure, like renal denervation, is that it can act independent of adherence and, in a sense, forms an always-on therapy for blood pressure control, and as a result, could be an important adjunct to the armamentarium that we have to control blood pressure today. We previously presented and published the results of the RADIANCE-HTN SOLO randomized trial, both at 2 months and at 6 months. Essentially, this was a sham-controlled randomized trial that was actually implemented in patients with elevated blood pressures who were taken off of their blood pressure medications to achieve a stable baseline, non-confounded by medications. Patients after this washout were then randomized to renal denervation on one hand versus a sham procedure on the other hand, and followed to a primary endpoint of 2 months. And at 2 months, the ambulatory blood pressure that was measured in both arms was different. It was lower with renal denervation compared to the sham control, a statistically significant difference. After that 2-month time period, patients remained blinded, and so did their physicians. And patients were then added back with blood pressure medications as needed in order to try to achieve control in a protocol-specified way. What we showed at 6 months was that despite these medications being added back, there were more medications added back in the sham group compared to the denervation group. And after adjusting for those differences, one found there were still lower blood pressures achieved with denervation compared to sham. So we take these results to mean that in a sham-controlled setting, renal denervation was associated first with a reduction in blood pressure off medications, and then after medications were added back, these results were still durable. What we sought to do with this crossover analysis was to then follow these patients further, especially those who had been treated initially with the sham procedure, and then determine if their blood pressures were elevated, what their response would be to a crossover renal denervation procedure. So within this study, we took an initial cohort of 72 sham-controlled patients. There were still 31 who were actually eligible for crossing over, and we then allowed those patients to cross over and have a denervation procedure. These patients were then followed after the denervation procedure at 2 months and 6 months, and at present we have follow-up data on 25 of those patients out to 6 months, all 31 at actually 2 months. This was the general baseline characteristics of the crossover cohort. They were not dissimilar in large part to those that were in the overall sham group, again representing just under half the sham control group as a whole. The mean age was 54, and one can see that in general the BMI was elevated in this patient population. The starting daytime ambulatory blood pressure was 145 with an office blood pressure of 146 systolic, and patients were on an average of 1.2 medications at the time of crossover. Notably, though, these patients were 23 months out at mean from their initial baseline randomization. So they had been followed for some time with medications on board, and then ultimately came to this crossover cohort. The procedural results of the crossover procedure were very similar to that in the main trial. Treatment was successfully delivered in all patients. Mean total admissions were only 5.7 with a total ablation time of 40 seconds, one of the advantages of this particular approach. The contrast volume was 146, and in those patients in whom we have safety data at this point, there were no adverse events observed. Here are the efficacy results in terms of blood pressure reduction. The daytime ambulatory blood pressure was reduced with the crossover procedure on average 11.2 millimeters of mercury systolic, 7.1 millimeters of mercury diastolic at 2 months, and in those patients who had 6-month ambulatory blood pressure monitoring, 12.2 and 8.6. Of note, the overall medications did not change appreciably. They perhaps crept down a little bit, but not really much of a difference between what happened prior and what happened after the procedure. Notably, the responsiveness rate was not 100%, but 71% of patients at 2 months, 68% of patients at 6 months had a decrease in blood pressure greater than 5 millimeters of mercury. And in these responders, the blood pressure reductions were even greater than shown here in the slide, which amalgamates the results among both responders and non-responders. So for those that responded, the blood pressure reductions were quite significant, greater than 15 millimeters of mercury systolic ambulatory. Now, these are the main results, but what should we remember from this? Well, first, we have to take these results in the overall context of the RADIANCE-HTN SOLO trial. Remember, also taking a step back even from the trial, that control of hypertension remains an unmet need globally, and renal denervation is adherence independent in its effect, and therefore can represent an adjunctive therapy to medications. We analyzed ambulatory blood pressure and safety data from 31 patients from the sham arm of the trial, who then crossed over and received renal denervation after a minimum of 12 months of observation. Remember, though, as I said, this has to be taken in the context of the overall trial, and as such, these patients were unblinded, their physicians were unblinded, this is open label, and so clearly subject to behavioral or medication-related effects that could also contribute to the observed results in addition to the denervation procedure the patients received. Despite that, what we observed is a daytime ambulatory systolic blood pressure reduction of 11.2 millimeters of mercury at 2 months, 12.2 at 6 months, in comparison to the new baseline these patients achieved at their initial time period in the crossover study. So that's on average over a year after their initial randomization. There was no increase in medication burden and no major events following crossover. As such, the results are consistent with the primary SOLO results, and there was no drug titration in this protocol itself. So in a sense, this provides some further reassurance regarding the durability of the procedure, at least out to 6 months at the crossover point. Thank you so much for listening. And once again, on behalf of all of my co-investigators, thanks for the opportunity to present at EPCR.
Hello and welcome to EPCR, the first virtual PCR meeting. My name is Felix Maffut. I'm an interventional cardiologist working here in Homburg-Saar in Germany. And I have the great pleasure of joining today Michel Azizi from Paris in France and AJ Kirtany from New York in the US. We're going to discuss the topic of renal denervation, and we will indeed talk about ultrasound renal denervation. And this wrap-up video is intended to discuss the latest evidence from the RADIANCE hypertension trial and the path to clinical adoption. As you may know, renal denervation has made some significant progress in the last couple of months and years. We have now 3 randomized sham-controlled trials that indicate that renal denervation indeed lowers blood pressure efficaciously and safely. And we're getting more and more interesting data from these randomized controlled trials. And I want to open up the discussion with my 2 friends here, Michel and AJ, and I'll ask them to reconnect you where we are with renal denervation at the moment. You want to start, Michel?
Thank you, AJ, and hello, everybody. Yes, I think you summarized also very well the situation today. We have moved from a period of great doubts on renal denervation a few years ago to really a new era where indeed the different trials have homogeneously and consistently shown a decrease in blood pressure induced by renal denervation, either with ultrasound, which is our interest today, but also with radiofrequency and alcohol renal denervation. And also the point is, which is very important, is also that, as you said, we have also different information and consistent information showing this that these technologies also have are not associated with an increased risk.
AJ, from your perspective, what are the most important steps that we made and that we completed in the past couple of months and years with renal denervation?
I think the biggest thing really was the sham-controlled studies, because there was so much question as to whether the efficacy was a real efficacy or what it would be like if you discounted the placebo or the sham effect. And so the initiation and completion of these randomized trials, I think, allow physicians and clinicians, statisticians, critics, whoever it is, to accept the fact that there is an effect of the therapy. And we were happy to be participating and leading the RADIANCE SOLO trial. That was one of the trials that actually showed this. And so I think we were going to go through a little bit in detail what that study was. And
please,
as you see here, basically the study took patients off medication. So these were patients who had blood pressures that were elevated while they were on medicines. There were some patients who were off medicines at baseline. And in order to get a steady baseline, patients were eliminated from their background of medications, followed, and then if their blood pressures remained elevated, randomized to renal denervation in one arm versus sham in another arm. They were then followed for 2 months, and the primary endpoint was ascertained at 2 months. And Michelle's going to go into a little bit of the details of the study results.
So unlike previous study, this trial included patients with mild to moderate hypertension, correct?
That's correct.
And patients were washed out or drug naive when they entered the trial.
Yeah, and I think that's a really critical part of how these studies were done, because if there's a wandering baseline or patients are taking medicines, you can't discern the actual treatment effect, the signal, from the noise, which would be the medications in the background. And so the primary design of this study was to get rid of that noise, get people washed off of medicines, randomize them, but then actually medicines were added back in a programmatic way, which allows future comparisons as well.
Michelle, you were key in the design and conduct of this clinical trial. Could you update us on the key initial findings that were published in The Lancet?
Yes, these are the primary results, and this is the primary efficacy endpoint, which was based on daytime ambulatory systolic blood pressure. I think also we should point out here that our different meetings as investigator organized by you when designing the different trials was also to focus on ambulatory blood pressure monitoring to get rid of also a placebo effect. So this was very important, and we made some assumption at the time of the design of the study that we would like to see a difference of around 6 mm of mercury in terms of daytime ambulatory systolic blood pressure. We focused on systolic blood pressure because systolic blood pressure is linked to the risk of cardiovascular event and to mortality much more than diastolic blood pressure. So this was our first hypothesis, and this is very interesting to see the 2 months data, and showing that in the denervation group, while patients are maintained blind to the randomization, and those who are following them also are maintained blind to the randomization, we have a drop of 8.5 mm of mercury in the denervation group and only 2.2 mm of mercury in the sham group, because some patients needed to resume the treatment because they had high blood pressure. As you see, the difference between group is 6.3 mm of mercury, with a confidence interval showing that this difference is highly statistically significant. So per se, this result shows that the proof of concept that renal denervation decreases blood pressure at least 2 months after randomization, with patient not put back on medications.
So it's a sham-controlled randomized trial powered to show superiority of renal denervation compared with sham. The trial met its primary efficacy endpoint at 2 months, and then patients were up-titrated to medication. Then the story is getting more complicated. Can you guide us through the 6-month results too, Michelle, please?
This slide is showing the changes in home blood pressure, in systolic home blood pressure, depending on the medication which are added at each visit. And these medications are added on the basis of home blood pressure monitoring. That is, if patients were not controlled, a first drug, which was amlodipine low dose, and then an ACE or an ARB, and then hydrochlorothiazide low dose, increasing dosage of hydrochlorothiazide, and finally increasing dosage of amlodipine or a calcium channel blocker. This was it established complete medication protocol. And as you clearly see from this slide, from the 3rd to the 6 months, we see that there is a parallelism of the two curves. That is, the drop in blood pressure always remains more marked in the denervation group in green compared to the sham group. And after 6 months of follow-up, the difference between groups adjusted on baseline and the number of medication is slightly less than at 2 months. It's 4.3 millimeters of mercury, statistically significant, and even with less medication in the denervation group. So 2 conclusions: while off medication and put back on medication, the denervation lowers blood pressure significantly compared to a sham procedure. And the procedure was safe. And on ABPM profiles, we could see that the blood pressure drop was present all over the circadian cycle.
So one could state that the efficacy of renal denervation is sustained long-term and even in the presence of antihypertensive medication, yes. Correct? Okay.
Correct.
AJ, at this year's EPCR, you presented the crossover data, which also provide very nice evidence for the efficacy of renal denervation. Can you summarize what the crossover data shows?
Sure, and I think an important point of what Michelle was mentioning with the 6-month data is those patients and physicians were still blinded to their randomization. And so these effects are robust, but then you want to see what happens to these patients after you follow them over time. And what the crossover results basically aimed to do was to summarize what happened to those patients who were initially treated with sham or placebo, who then remained hypertensive, and at that point potentially warranted further therapy with renal denervation in addition to what they were already taking medication-wise, and to see if it had an effect. So the advantage of this is that it follows patients over time. It's open label though, so patients can clearly change their medicines, but what happens to their blood pressure after they subsequently get renal denervation? And what was interesting is that the average number of medications relatively stayed constant, but after renal denervation, there was a further decrease in blood pressure that was, greater than 10 millimeters of mercury by ambulatory blood pressure monitoring at 2 months after the crossover procedure. And then in the 25 patients that were followed at 6 months after the crossover procedure, it was 12.2 millimeters of mercury. Now, the reason for the difference in numbers is because some of these patients are still undergoing follow-up. And overall, the median time of crossover was almost 2 years after the initial study enrollment. So what we can see here is these are patients who, despite being in a study, which typically does lower blood pressure, remained with elevated blood pressures, and then they had denervation, further lowering their blood pressure in addition to the medicines they were on.
And the efficacy, the blood pressure falls documented in patients that crossed over were larger compared to the initial 2 months and 6 months data. Is that related to unblinding of the patients, or where does that come from?
Yeah, I think that some of this is no doubt related to unblinding. And in a sense, the advantage of a sham-controlled or placebo-controlled trial is it gives a true estimate of treatment effect when you control for everything else. But in the real world, we don't actually sham control patients, we don't blind patients, and we actually provide them information, we provide them medications. And so these data, in addition to the sham-controlled data, I think are together form a picture. Only one in isolation. If you have uncontrolled data in isolation, you may doubt it, but this allows you to sort of imply at least what might happen in the real world. Now, it's not true that every patient responded. I think these curves show you that not everybody responded to this crossover therapy. But among those that did, the drops in blood pressure were quite marked, and good news for patients because we know that that ultimately correlates with long-term outcomes.
Very interesting. So that ultimately leads to the question, which patients should then be treated with renal denervation? And I'm asking this question to the both of you, one probably more from the European side and one more from the US side. So as of today, where do you think renal denervation may add to the armamentarium of antihypertensive treatment approaches? Let's start with Michelle. which patient is a candidate for renal denervation at the moment?
Well, I would say, continuing in the trial, all the patients who have the criteria to enter trials. So this is my first answer. If we want more to extrapolate from the data we have to go back to the analysis of the responders and why some people respond more than others. So what we learned from the different studies is the younger you are, the better you have the largest response. The more obese you are, the more you have a profile of sympathetically driven hypertension, you will have a better response. If your heart rate, these are the works that you have done, is higher, you will have also a larger drop in blood pressure, or the higher is your blood pressure, you will have a larger drop in blood pressure. So these are the profiles who are a little bit more responsive to this therapy, and we should continue working to find out who is the best candidate to undergo renal denervation.
And from your perspective, AJ?
Yeah, I think that we're sort of waiting for these devices to be approved here in the United States, so it's a little bit different. But I think if the data holds out the way they are, and there are going to be some additional trials that will report out very soon. Felix, as you know, because you're part of the steering committee with us on RADIANCE-HTN Trio, enrollment at this point is complete, and so we're sort of awaiting the results of this, which should be forthcoming. And there are additional studies in Korea as well. So the bottom line is that when these trials come out, my feeling is that patients that are either still elevated blood pressures despite medications or unable to or unwilling to take medications would be the best target candidates for renal denervation.
Great, thank you. So our 15 minutes of discussion are coming to an end. I think it's quite amazing to see which progress we made. We have evidence now clearly indicating that renal denervation lowers blood pressure. I think that can be stated now. We have the evidence that supports this statement in the presence and in the absence of antihypertensive medication. The crossover adds to this data as it provides more real-world information about patients that are receiving renal denervation with uncontrolled hypertension. Many more trials are recruiting patients, will be finalized shortly. AJ pointed out that the Trio trial, a trial that focused on patients with therapy-resistant hypertension on a triple fixed combination, finalized enrollment. So these results will be available hopefully soon. But we're also looking into new indications, atrial fibrillation, heart failure, chronic kidney disease, much more to come. I think in the next couple of years, we will see this body of evidence growing. I'd like to thank you all for listening, particularly thanks to Michelle and AJ for joining me, and have a nice ePCR. Thank you.